Hello, I'm Sharrie Harlin, program host for Reid Beside You. Today, as our guest, we have Dr. Dana Reihman. Welcome, Dr. Reihman. We always like to give our guest a insight into how did you come to our area? So, where are you from, and where did you receive your training?
I went to high school in Connersville. I'm a Spartan going way back, and my dad used to run the Visteon plant in Connersville for a number of years. I did my undergraduate in Bloomington, and then my medical school, my internship, residency, and fellowship all in the University of Medical Center in Indianapolis. And I've been in Richmond in practice with my wife, Dr. Eileen Cravens, since 1987. So I've been here for many years now in Richmond.
Great. And today we're going to talk about sleep medicine. And Dr. Reihman, how did you become involved in sleep medicine?
You wouldn't think that would be the typical role for a lung specialist like myself. I do quite a bit of critical care medicine also. But the major problem that I see in sleep medicine, our sleep laboratory, we'll talk about that, is sleep apnea, which is a breathing-related difficulty. So when this condition was really described many years ago, a lung specialist got involved in this because it's a breathing disorder. So it's actually been nationally, the majority of sleep labs are run by lung specialists such as myself, although neurologists and other specialists are involved also.
Okay. So, well, the main question is, why do we need sleep? We read a lot about that Americans don't get enough sleep. So why do we need sleep?
You know, you would think that would be a cut and dried answer, and that I'd be able to answer that. But there's still much research going on. Actually, it's not exactly clear what happens with sleep. Now, we used to think that during sleep, the brain sort of went into hibernation, and it was kind of resting the brain. We now know that when you sleep, the brain is actually very active. And what people now think that one of the roles of sleep is that during sleep, the brain, the cells sort of dilate up a little bit. A lot of the toxic waste products of the day are cleaned out. It kind of refreshes the brain for new input the following day. We know that without sleep, you don't think as clearly. The brain just doesn't function as well. Don't ask me why you dream. I don't think people still know that what that's involved with. But it is clear that without sleep, none of us functions well. And that creates information about that. A common question I'm asked, how much sleep do you need?
Right. That was going to be my next question.
Yeah, that's one of the most common questions that people ask. The rough answer is the younger you are, the more sleep you need. A child, an elementary school child, really benefit from 9 hours of sleep or more a night. Typically in high school, you benefit from 8 to 8.5 hours of sleep. The average adult would typically need, we tell people about 7 hours of sleep a night. As you get older, particularly when you get into the Medicare age, probably need a little less than that. And the problem there is your sleep quality is not as deep. We have progressively deeper stages of sleep. The most refreshing sleep is the REM sleep, the rapid eye movement sleep. Typically occurs about 90 minutes of sleep. As you get older, your sleep quality goes down. And that's a lot of older adults have complained of suboptimal sleep quality as they age. But it's kind of a natural function of the aging brain to have that complaint.
We have to hear people that say, I can't sleep, I need a sleeping aid. What about sleeping pills?
You know, in my own practice, I really discourage use of sleeping pills. Like any medicine, they have side effects. There tends to be a cure the next day. I think that using some sort of sleep aid in some sort of acute situation, stress in your life is okay, but long term, I really discourage that. We actually see a fair number of insomnia people in my practice, and we work with things like cognitive behavior disorder therapy or sleep restriction or improving your sleep status, doing things in the bedroom to make your sleep quality better, trying to avoid things like watching television in bed, using the bed most of the sleep, to try to improve sleep quality. I really discourage the use of sleeping pills long term. And what I find is that once you're on this, it's very difficult then to get off those.
Okay. And so for a person who has a sleep problem, well, how are they evaluated, or where could they be evaluated?
Well, it obviously depends on what your situation is. Your family physician obviously has certain knowledge about sleep and often help you, particularly with hints on to maybe get a better night's sleep. We have a sleep disorder clinic at Reid Hospital that been in action now for really a number of years. Our sleep disorder center is located across the street from the old Reid Hospital, and we run sleep studies about 5-6 nights a week now. Now, what we mainly deal with there is sleep apnea. Now, we see a fair number of patients with things like insomnia, other sleep disorders too. Rarely we see an individual have sleep disorders such as narcolepsy, for example. But probably the majority of individuals come in because they have sleep apnea, which is a sleep disorder oftentimes related to loud snoring and sometimes being somewhat overweight. These individuals typically have suboptimal, disrupted sleep due to breathing difficulty in sleep at night. And we work very hard with these people to try to improve their sleep quality and get that problem corrected.
And what you said the causes of sleep apnea of the overweight. So how would I know if myself or my spouse was having those problems? How would we?
The two most common complaints that I see that would bring a person to a sleep laboratory would be, first, that the spouse snores, that the individual is a very loud snorer, or that they're actually stopping breathing. The second thing is that people come to us because they complain to their family doctor, I'm just so fatigued or so tired all the time, I can't stay awake during the day. We have these progressively deeper stages of sleep. To get a good night's sleep, you got to get that deep sleep. And what I find is people with sleep apnea, they don't get the deep sleep because they wake up so much from stopping breathing. We have several graphics here. Maybe we can show the first graphic, if we can bring that up. The first graphic shows the airway during normal sleep. Now, if you notice those blue arrows coming down through the mouth, through the nose, the air comes through the back of the nose, through the back of the throat, goes into the lungs, and the typical individual doesn't stop breathing. They breathe fine all night. And that's what you want. These individuals typically wouldn't snore. But if you look at the second graphic we have, people with sleep apnea, they have a problem with their base of their tongue. When they fall asleep at night, their tongue tends to fall to the back of the throat and near the airway. As that happens, generally the individual will begin to snore. And then eventually the tongue goes all the way back of the throat. The air can't get it all. And at that point, the person actually stops breathing. Their oxygen level starts to fall, and they actually begin to smother to some degree. So that causes their blood pressure to go up, they're smothering, their pulse goes up. I tell people they get a shot of adrenaline, and eventually those things wake them up. They wake up and start to breathe again. Immediately then would fall back asleep, tongue back throat, near the airway, again stop breathing. So all night long, you're stopping breathing, waking up, falling back asleep. Because you wake up so much at night, you don't get a good night's sleep, and then you're very tired. And I've seen some people get such a poor night's sleep that they literally have driven their cars off the side of the road, get fired from their jobs. I think over a long period of time, that adrenaline getting system, that the sympathetic stimulation you get from stopping breathing, the smothering, it makes your blood pressure go up during the daytime. Your pulse, your oxygen level goes down at night. In the long term, those have bad effects. There's a high association between sleep apnea and high blood pressure, between things like elevated cholesterol, incidence of things like strokes, heart attacks, even diabetes. It's shown that therapy, for example, for sleep apnea can help your blood pressure go down. I sometimes see individuals who have been on 3-4 blood pressure medicines. They treat their sleep apnea, and the requirement for blood pressure medicine falls. The cardiologists know that there's high incidence of cardiac disease in people who have sleep apnea, particularly atrial fibrillation, abnormal cardiac rhythm. We see patients all the time. Someone overweight individuals develop sleep apnea and then develop atrial fibrillation. And therapy seems to help those cardiac arrhythmias also. Cardiologists are very knowledgeable about referring people to our sleep laboratory for these issues.
So you had mentioned the therapy that's available. So exactly what's a sleep study?
A sleep study, patients come into our sleep laboratory generally around 9 o'clock at night, and we put them in a big, comfortable bed. We then monitor their pulse, their breathing, their oxygen level. We even monitor their brain. We start getting deep sleep. We watch them until around 5 o'clock in the morning, then they go home. And during the night, we observe to see if they have apnea, if they stop breathing. If they do, we'll generally then prescribe CPAP therapy. Now, if we can show the third graphic, CPAP is a little air compressor device that's plugged into the wall in your bedroom. And it takes room air, compresses, and it passes that compressed air through this somewhat fitting master windows. And the air pressure push your tongue out of the way, and therefore you never stop breathing when you sleep at night. CPAP is one of the few therapies in medicine that is 100% effective and has no side effects. It always works. Now, some people don't like wearing that CPAP mask, and that's where we come in our clinic. We have a sleep clinic at Reid Hospital during the daytime, and we see people after they've been on their CPAP for a period of time. We work with them trying to get that CPAP working for them. We perhaps may put a more comfortable mask, we change the CPAP pressure. We work with patients very hard to try to get them comfortable with this because we know that CPAP always works, has no side effects. If you wear it, it's going to fix this problem. And not only that, you'll feel better. Better night's sleep, more energy, more like to exercise and lose some weight. You aren't so chronically fatigued. So it works real well, and we work very hard to try to get people to cooperate with their CPAP and use it all night like they should.
And so you said there's an opportunity, so sometimes you have people that spend the night, and then there's some studies that are done during the day as well.
Yeah, that's a good question. We will also sometimes do daytime studies too in the patient's own bed. Or actually, I should call it, they're actually home studies that you come in the afternoon, you pick up the equipment, take it home with you, and wear it in your own bed that night. Home studies aren't as accurate. We can't observe your sleep stage, but for some individuals, particularly patients who wouldn't want to sleep in a sleep laboratory, it's adequate to diagnose your problem and allow you to get a CPAP machine. And we can still then work with you on getting the correct therapy. We can't actually titrate your CPAP pressure. In the laboratory, if you come in, we'll actually work with you at that night in the laboratory to get you on the right mask, titrate the right pressure, make sure the pressure is not too high, not too low, make sure you get a good night's sleep with it. But home study is usually adequate to prove you have the problem or prove you don't have the problem, and then move on from there in terms of therapy. CPAP or one of the other therapeutic options. Well, sometimes we're individuals with things like dental appliances. There are a few other therapies that are out there we use for sleep apnea too, but not quite as effective as the CPAP.
And once you were diagnosed, what's the typical time to find? How long approximately can you give the final diagnosis, or what's the next steps?
We're very aggressive when people refer to our sleep clinic about getting them diagnosed and treated. We try to work very quickly to get them on the correct therapy and then follow them along. We'll typically see patients every few weeks initially to make sure that they're adapting to CPAP and it's working for them. I think we've been able to really improve the care of sleep apnea in this community considerably with our sleep disorder clinic now. In the old days, the patient would sort of see their family doctor, they get the machine, wouldn't really know what's going on. We have a very knowledgeable staff at this clinic that works very close with people to try to get them to work with their CPAP and wear their CPAP and make it comfortable so that they'll benefit from it.
Okay. Well, thank you very much. It's been very enjoyable, and we learned a lot about sleep apnea. Thank you, Dr. Reihman.
Thanks, Sharrie.
Hi, I'm Dr. Jason Casselman. Welcome to Reid Allergy. My training is actually in Michigan, at Michigan State University, where I went to med school. I did my residency in internal medicine in Pontiac, Michigan, which is a suburb of Detroit. And then I went down to Cleveland for 2 years to do an allergy immunology fellowship in Cleveland, Ohio. And that's kind of what brought me here. So some of my hobbies are just doing different outdoor activities. We love camping and hiking. The different trails in Indiana are fabulous for biking as well. I'm a huge sports fanatic. I love all kinds of different sports. Basketball is my personal favorite. So March Madness is the greatest time of year for me, watching college basketball. So the question was, what's the difference between the care that is provided by allergists versus other providers such as family doctors and dermatologists and things like that? And the truth is that all kinds of different physicians can manage allergic disease. So whether it be medications or environmental controls and things like that. I think the difference comes in, first of all, the severity of the symptoms. If they've been ongoing and difficult to control, it may be worthwhile to send the patient to an allergist at that point. There are different things that we can offer that perhaps family doctors and other providers can't offer, such as allergy testing within the office, allergy injections if we feel that the symptoms are severe enough where the patient may benefit from that type of treatment. So it's kind of severity and duration of symptoms which would prompt evaluation by an allergist. Yeah. So the question is in regards to childhood versus adult allergies, and when you can and can't develop them, and how long they last, etc. So the truth is you can develop allergies at any age. Generally what we see is allergies are an inherited genetic condition, a lot of times passed on from generations down. If you develop childhood allergies, there is a possibility, either with or without treatment, that you can outgrow these allergies over time. but you can also develop allergies later on in life. So anytime symptoms present themselves, it's a good idea to get evaluated one way or another. We can hang on to allergies for many, many years. Some people never grow out of them, but we can certainly treat them and try to control them as best we can in the office. So the question is what is the difference between cold and flu symptoms versus allergy symptoms? And the truth is, it can be difficult to distinguish cold and flu-like symptoms versus allergies at times. Some of the same symptoms that cause allergies could cause, cold and flu-like symptoms as well, including runny nose, some tearing of the eyes, sore throats, coughing, etc. So really the way we differentiate it is a few different things. Number one, what's the pattern? Has this been going on for a longer period of time? Is this something that is relatively new, has been going on for a few weeks' time or even a few days? And number two, are there any fevers, body aches, things like that would be more suggestive of infection that would be caused by cold or flu-like symptoms? The question is, if you've just recently moved to the Indiana area from a different state perhaps, and your allergies are starting to flare now, why is that? Well, the answer is that different states have different types of pollen. So it could be the fact that you were used to the pollens in that state and your body had sort of intolerance to that pollen. And since you moved to the state, you're encountering new pollen species from different types of trees and grasses and weeds, etc. And some people become allergic over time to new things that they haven't had exposure to in the past. So the question is in regards to allergy injections and allergy shots, what that is, what it entails, and how it's effective for the treatment of seasonal allergies. And basically what allergy injections are is the different things that you test positive to on testing are basically what gets put in your allergy injection. And what we do is we start at very, very small doses, very, very minimal dose, and sort of build you up over time. So giving you increasing doses over time to what we call inducing tolerance in the patient. So basically, if you do get exposed to those things over time, your body reacts less to those things because you're sort of used to it. Basically, it involves you coming into the office, getting an injection with a very, very small needle under the skin, about once a week as a build-up protocol calls for, and then once we get you through that build-up phase, once you're on the maintenance injections, it's about once a month at that point in time. The question was in regards to pet allergies. How do we manage them, basically? So we all love our pets, whether it be cats or dogs or other pets that we have. So if we find out that we're allergic to our cat or dog or other pets, we have to come up with a treatment plan, which we do in the office. So actually what we're allergic to with our pets is not the hair, it's actually the skin, so it's the dander. So basically there's different things that we could do to try to avoid these things. What we really recommend ideally is to make your bedroom a pet-free location. If the pet is in the bedroom, it's always a good idea to keep a HEPA filter in the bedroom, which sort of purifies the air from the pet dander as well. It's important to clean our pets very frequently as well to try to keep the dander very, very low. And if that's not helping, either medications or allergy injections for cat or dog are always a good option as well. Question was in regards to gluten. Gluten is a little bit of a hot topic in the media these days, and a lot of people avoid gluten. And there's different reactions. I always tell my patients we can always have different reactions to food, whether it be allergy or not. So our job as allergists are to identify what is a true allergy to a food. And the classic example is a child with a peanut allergy. They ingest the peanut within 20 to 30 minutes, hives, swelling, shortness of breath, very serious issues. But you can have non-allergic issues with foods as well, and gluten is included in that, whether it be headaches or just not feeling well when they ingest the food. So what we really try to do as far as gluten would be to identify what's true allergy and what's more of an intolerance to those things. And that we can clear up with clinical history, just talking, and also some allergy testing in the office. So the question was in regards to when should I bring my child in for food testing if there's a high risk in the family. And the answer to that is a little bit complicated. Basically, if there's a family history, mom, dad, brother, and sister have food allergies and there's a cause for concern, we don't want to reinstitute things in the child's diet without getting evaluation. It's never a bad idea just to come in and chat with us. We can go over history in the family, what the family member is allergic to. We can even evaluate it with testing, like we mentioned, skin testing in the office that's very, very quick and can easily identify any particular foods that the child may be at risk for developing an allergy to. So what we'd do is we'd have you in the office, we'd kind of go over the history, maybe do some testing at that point in time and determine whether or not it's going to be safe to institute that food in the diet. So basically the expectation on your first allergy visit with me will be to sort of discuss an overall clinical background that you have. We'll go into depth on your allergy symptoms that you're having, try to identify any patterns or triggers for your symptoms, such as seasonal patterns, exposures that may trigger symptoms, and get sort of a broad overview on that. After that's completed, we may proceed with skin testing in the office, which can be performed. It's a very simple, easy way to evaluate allergies to different things. It takes about 15 minutes and it's completed. After that's all finished, we'll sort of wrap things up in the office, discuss different treatment options, and come up with a plan that's personalized for each particular patient. So in regards to diagnostic testing that's offered in our office when you come to visit, we have different things that we can do depending on the patient's complaints and symptoms. So for seasonal allergy type symptoms, generally what we do is skin testing that's can be performed at the time of visit. It's very easy. Little skin testing trays that we have. It's basically little plastic devices that scratch the skin either on the back or the arms. And usually within about 15 minutes we can tell if there's any reactivity. It's very easy. For asthma evaluation, we also have this breathing device that we can perform in the office. Basically the patient blows into this device very forcefully for a few seconds, and we can evaluate different volumes and different measurements for their breathing to see whether or not we think asthma is a possibility for the reason that they'd be having shortness of breath or coughing or wheezing complaints. So those are some of the diagnostic services that we offer that we can get done at the patient's office visit. And in regards to the different treatment options that we can offer, I usually like to separate our treatment options based on 3 different categories. And despite the fact that you may think every allergy office is going to automatically go to allergy shots, that's not always the case. So we direct our therapy based on every particular patient's specific case. The first category would be what we can control in our environment as far as allergies go, whether it be behavioral modifications with our pets or avoidance of different things such as pollens and dust mites. The second option would be allergy medicines, the different allergy tablets and pills, nasal sprays, eye drops. There's a whole bunch of different options that we can offer. And the third category would be if symptoms are continuing to be refractory to our treatment and our environmental modifications. Allergy shots are a very effective way to control our allergy symptoms as well.